Well, hello everyone. Welcome to night 2 of our Treating the Whole Person Optimizing Wellness Conference. Super excited for our sessions tonight. If you can see and hear me, then you are in the session with Dr. R. Norman Harden. And he is going to be speaking about clinically relevant subsets of CRPS. He, like I said, is our guest speaker this evening. He's the Senior Associate Editor at Pain Medicine and a Professor Emeritus at Northwestern University. He's also a member of the RSDSA Board of Directors. And we thank you for being here with us this evening. So I'm going to turn it over to you.
All right. Hi, folks. All of you that had to sit through me and my technical difficulties, I apologize for that. I called in my IT specialist, who's my son, and he has informed me that not only is my computer very old and not up to the task, I'm apparently too old to be up to the task, but I'll do my best today. And what I wanted to talk about basically is this. We have all noticed that a lot of the clinical trials that have been conducted recently have failed. And, you know, being a lab rat, you know, I feel responsible and have to look into that. But I feel I have an answer to why that happened. But I feel I also have a solution to that. And this is going to be a little dense tonight, but hopefully I will convince you that this is a very important direction in terms of the research for CRPS. So here are my conflicts. You've heard about this, but the important thing that we're the International Research Consortium for CRPS. So what we're going to talk about is first is the failures in research, and I'm going to call this the p-value problem. So in recent large randomized controlled trials, there's always a subset of subjects that are responsive to any of the drugs tried, any of the drugs that I've analyzed, yet not enough of the population at large, the big population in the study responds to that intervention to yield statistical significance, or the p-value of 0.05. So the p-value problem underscores that although Budapest has proven to be a really good clinical screening criteria and useful in the initial screening of subjects for research, it is not proven to identify and match disease mechanisms, or as we'll call it, the subsets or treatment targets, to the specific mechanisms of the intervention. To identify disease mechanisms and match those to specific mechanisms of the intervention, of course, is the key to all research, but that has not been achieved with sufficient specificity yet with CRPS research. So I have to drag you back through the history of diagnosis, diagnostic criteria, and then move on to diagnostic subsets. But before we had criteria of any sort, you know, doctors said, well, I know it when I see it. You know, we certainly had experience enough to say, we see a disease that's primarily characterized by pain and autonomic dysfunction. And, you know, it was pretty clear. And of course, the cases we were seeing back then and identifying back then were very dramatic. So there was no question that we were dealing with CRPS in the cases that we first started to study. But along about that time, because it was the Wild West out there and people were, you know, saying, I know it when I see it, and people were all treating different things and talking about different things. There wasn't even a common name back in the early days. The first thing that came along, the Orlando criteria, or what came to be called as the IASP criteria, was designed to create sort of a large umbrella so that nobody was left out in the cold, nobody was left out in the rain. And what we had was a collection of a bunch of different mechanisms. We started to get an inkling at that point that there were a bunch of different mechanisms that were brought under the rubric of the Orlando criteria, if you will, that define CRPS. In other words, it's a multifactorial disease, lots of different things going on. And this first criteria had a lot of problems. Remember what I said? It was meant to be a big umbrella that would not let really anybody get out in the cold. And in doing that, it was not very specific. It's very sensitive criteria, but it was not very specific. In other words, a lot of things that weren't CRPS got under the umbrella. And there were problems with the original first IASP criteria. Look at number 3 here. One of the required things was that evidence at some time of edema, changes in skin blood flow, or abnormal pseudomotor activity in the region of pain. So this is evidence at some time. So people would come in and say, you know, my skin got red and hot, and it was very painful, and it may have been a little bit swollen, and you would make the diagnosis of CRPS, and of course that was much too sensitive and not nearly specific enough. So we began the process of refining the Orlando criteria and developed ultimately what we called the Budapest criteria, or this is properly called the IASP version 2 criteria. So we set out to develop a logical, statistically derived criteria. This would be based on signs and symptoms that were common to CRPS patients. And this is key to the IASP 2. This criteria can be acquired in any clinic by any physician, needing no special equipment or training. That was very deliberate, so that any doctors anywhere that, you know, of course, had been to medical school and been trained in basic medical procedures could make this criteria. And here, I'll get back to this in a little bit. But it mentions a certain number of symptoms and a certain number of signs. If you get that number, you would make the criteria. This is the IASP 2. I use my umbrella here to indicate that now we're getting much more people that actually have CRPS. And you'll notice there's one little green guy there that snuck in. So that it's not perfect, but it's much better now, much more specific in terms of identifying the people that have CRPS, and it still retains a good deal of sensitivity, so that we don't exclude people that actually have CRPS. And this is a complicated slide, but look down to the bottom where it has the yellow, where it says if you have 3 symptoms factors and 2 sign factors, you develop a sensitivity of 0.85, which is quite good. It's not the 100% sensitivity that we had for IASP 1, but it has a specificity of 0.69, and that's excellent for any clinical syndromic type of criteria. So we achieved our goal of having good sensitivity and much improved specificity, and we thought that in itself would be enough to move the ball down the field in terms of identifying specific treatments for CRPS. But unfortunately, that's not how it went. And the big problem is that CRPS is a multifactorial disease. In other words, there are multiple mechanisms of disease. And I've listed just a few of these here, and start thinking in terms of subsets of this disease. Some of the people have peripheral sensitization. For instance, hyperpathia allodynia. You know that hyperpathia is that you have usually tested with a pinprick instead of just a mild pain. You would have an extremely severe pain, and it would last a lot longer than the unaffected side. Allodynia, on the other hand, are things that are not normally painful that are now quite painful, such as warmth or cool or light touch. Other multifactorial things that we find, of course, there's immune types of CRPS. There is autoimmune types of CRPS. I know Dr. Goebbels talked to you about that last night. There are neuropathic disorders specific to CRPS. Some of the patients get central sensitization. And again, we go back, this is also a cause of hyperpathia and allodynia. And then, of course, back to the old school thought that the autonomic nervous system is prominent in CRPS. And we do know that it's seen in most cases if you look back to the signs and symptoms. So the factors that we had should now perhaps be considered more like subsets and targets. In other words, factor 1 for making the criteria has the hyperalgesia and allodynia that I discussed. Factor 2 has temperature asymmetry and color changes from side to side, unaffected versus affected side. Factor 3 is actually broken up into people that show edema or swelling of the affected part. And also statistically, this factor locked up with sweating asymmetry. Factor 4 is decreased range of motion and signs, and decreased range of motion symptoms. There's motor dysfunction of all types. There's trophic symptoms. It's not my purpose to go into this in great detail. But what we noticed is that if we drilled down into the people who were getting the Budapest criteria, we would see that there were some people that had prominent features of vasomotor changes, prominent features of pseudomotor changes or bone changes, motor changes, dystrophic changes, etc. And you can see now that under Budapest, you've got these what we're calling clinically significant or research significant subsets. These are in the clinic, these are your targets. This is what you go after with your interventions and your drugs. And in research, of course, these are the subsets that you want to identify specifically so that you can match them with drugs and interventions that are likely to help. So in terms of these clinically significant or clinically relevant subsets is probably the more common verbiage that you will hear. The first thing, of course, is to identify this. Now, this actually gives us a very interesting opportunity because we're using the Budapest criteria to screen people to the researchers. So they know that, you know, we're in the ballpark. These people have CRPS by that IASP type 2, but we can use specific tests that are objective or quasi-objective. In other words, quantifiable measures to identify the subsets. And I'll talk a lot more about that later. The second part of the clinically relevant subsets is the validation. Target subjects with prominent features of a subset with empirical treatments. That means treatments that are likely to help. If you have a cold, blue, sweaty limb, we know that that things like sympathetic blocks actually alleviate that, at least for a period. So this would be an empirical treatment that we would try versus the subset that we have identified using objective or quasi-objective quantifiable methods. Now, the really nifty thing about this for a researcher is the analysis part, because after you've identified the subset, you've used an empirical treatment that is likely to help that, you go back to use the objective or quasi-objective measure as your outcome. In other words, now we have something that's a number. It's no longer something that is what the patient thinks or what importantly what the physician thinks is happening, and they're no longer subjective outcomes like pain. We're obviously pain is a premier symptom. But pain is fully subjective. It doesn't have a way to measure it, and it doesn't have a means of quantification. So this is really what's going on with these clinically relevant subsets: identification, validation of empirical treatments, and then analysis using the same measures that we used for identification. And we have a lot of things that we can use to objectify and quantify our outcomes. Things like the fMRI now are allowing fully objective measurement of the features of pain as we see it in the brain. And then there's a whole list of other things. There's quasi-objective sets. You move down to the quantitative sensory testing. That's not fully objective, but it is at least quantifiable. So we're moving away from subjective measures like pain or patient report of disability and moving into machine measured things. In other words, fully objective or quantifiable outcomes. We think this will solve the p-value problem, but I'll go on and hopefully I can convince you of that. For instance, in the old diagnostic criteria, we knew that there were reports from patients or symptoms about allodynia and hyperalgesia, and then we had testing for what we call signs in the clinic, where, for instance, to measure hyperalgesia, we'll touch the patient with a pen, and it'll be severe pain lasting much longer than the unaffected side, and we'll take a little wisp of cotton and measure allodynia, but this can be measured with the quantitative sensory testing. Or here's an example of the fMRI, and we know the parts of the brain that are going to light up on fMRI and CRPS now. There's a lot of very, very technical things, but we move entirely in the case of things like the decreased regional anisotrophy, or connectivity is the word you'll hear, which is fully objective, no longer tied to the subjective report of pain. Here's an example of fMRI in a way that we use it to objectify pain. We notice the visual analog scale pain score at the top. We take a picture, and then we give a drug, and then we wait a certain amount of time, and we notice that the picture begins to change. In other words, the red parts that lit up when the patient was reporting pain of 7, 8, 9, and 8.5 is now. Can you see this arrow here? Can everybody see this? I'll use this to point with. But anyhow, the visual analog scale up here at the top, you give the drug, you notice that the red highlights are going away, and as it happens, the pain is going down. So here's your subjective report of pain. Here's the quantitative portion in the fMRI. This is just an example of the improvement that we hope to achieve with the clinically relevant subsets. To go back to the old school diagnostic criteria, Budapest criteria, we'll see vasomotor changes. This means color changes, and this means temperature changes that not only the patient can detect, but the physician can detect. But we have a way to fully objective measure that with quantitative infrared telethermography. And I think everybody would probably agree there's a difference from side to side. It's the right side that is chronic CRPS, and it's very cold relative to the other side. So we're measuring temperature side to side in a fully objective way. Another way is laser Doppler, measures the same thing exactly, but it's how much blood flow you get side to side. You can even objectify things like edema. Yeah, I mean, everybody would agree this is swollen up, but how do you quantify this? And you might take a paper ruler and wrap it around the arm there and compare it to the other side and see that it was larger on the one side. But that's kind of a sloppy way to do it. And speaking of sloppy ways to do it, but a fully objective way to do it is you take the unaffected side and put it in a bucket of water and see how much water it displaces. And you can actually measure that. And then you put in a hand that's swollen and edematous, like that picture I showed you earlier, and that displaces more water. And now you have a fully objective test. We have sweating changes. We have devices to measure the sweat called QSART. I don't think there's more than 2 or 3 QSART machines working in the country now, but it's just an example of something that was used earlier, discarded as too complicated and cumbersome, but now may make a comeback if we identify that sweaty component as a clinically relevant subset that we want to design a treatment for. And this is one of the most interesting examples, so bear with me here. This is a triple phase bone scan, and I don't know if any of you remember this. This is kind of ancient history. It used to be the diagnosis of CRPS was made by triple phase bone scanning, but then they determined that it was not really good. It didn't have good sensitivity or specificity. And the way this works is you take this radio label or radioisotope and you tie it to a bisphosphonate. Now, bisphosphonates are drugs that treat bone problems, such as osteopenia. You would use a bisphosphonate to treat decreased bone, for instance, in an older person that was losing bone mass. But when you have disease of bone, it lights up. In other words, the bisphosphonate working on bone dysfunction drags the radioisotope into the joint. So you can see the affected joint is darker here. Now, the reason this is so important and so I think interesting to our subject tonight is that the triple phase bone scanning uses a bisphosphonate. Bisphosphonate goes to the area of the bone that is damaged, that is dysfunctional, and it drags this radioisotope. But wouldn't it be interesting if we were looking at a bisphosphonate like the two bisphosphonates that have recently had failed trials as an entry point into the trial? In other words, patients that had triple phase bone scanning abnormality would be patients that would be a candidate for a bisphosphonate, like neridronate or zoledronic acid, which, as most people probably know, are both failed trials. I have to admit, I was involved in both of those trials, and I begged and pleaded with the principals of the drug company to let me at least have a portion of patients where I could do triple phase bone scanning to see if that identified patients that were going to respond to the drug. Unfortunately, they would not let me do that. They couldn't afford to do that, or there was all kinds of reasons that it didn't happen, but they were failed trials. So the biomarkers or the objective tests hopefully will ultimately develop as a gold standard for the identification of different clinical subsets or research subsets and measuring the efficacy of tailored interventions. And this is, again, the mechanism of disease as juxtaposed with the mechanism of the intervention. Now, the only subsets that we've actually studied so far, validated so far with research, are kind of clunky, I have to admit. But these are the ones that we do have the data. And the first is basically florid CRPS. This is back to the old I know it when I see it type of CRPS versus the less florid versions of that. And that was we just looked at all the different things that were going on and let the computer tell us what subsets to focus on. So that was the first one that came out, florid versus less florid, and nobody uses that anymore. Now, there is something that is very logical, and again, a different type of computer analysis, statistical analysis, shows us that cold versus hot CRPS was a relevant subset, was an important subset. And if we do consider this as something that we're going to study in terms of clinically relevant subsets, we would look at something like the cold CRPS and say, well, how do we improve the blood flow? The reason a limb is cold is because it has decreased blood flow. How do we improve the blood flow? Well, we can improve that with sympathetic blocks, or we can improve that with calcium channel blockers. So you take the identified cold CRPS, you measure the infrared telethermography to quantitate that. You use an intervention that logically or empirically would treat that, such as sympathetic blocks, and then you would see what would happen. You would also use the infrared telethermography to measure improvement. In other words, you measure how bad it is, you give the intervention, and then you use the same measurement to come back and see if there's been an improvement or an outcome of efficacy. Other clinically relevant subsets may simply be the factors that we use for the Budapest. We're theoretically getting all the signs and symptoms to make Budapest diagnostic criteria in everybody, and actually that's supposed to happen every time you go see your doctor, so they can measure improvements or even remission or even cure. But if we take these factors, the pain factor, factor 2 is the temperature and color factor, 3 is edema and sweating, and 4 is motor stuff and dystrophic changes. We might use these any one of the 4 factors as a clinically significant subset, but there's a lot of debate internationally amongst the research community as to how we should proceed to validating this idea, this theory that they're clinically relevant subsets is going to be a tremendously important direction for our research in CRPS. All kinds of other subsets. I mean, you could do the subset that had small nerve damage. Some of you have probably heard about this, where you lose the small nervous system. You have damage to the small nerves. And of course, the small nerves send the pain message to the brain. So damage to small nerves probably correlates with some of the peripheral manifestations of allodynia and hyperalgesia. And this is something that you can actually count the small nerves in a pain and compare it to the unaffected side. And this may be a clinically relevant subset that we would identify, treat, and measure. Everybody's heard about cytokines probably now. This is actually how it works, but it would identify peripheral immune changes. And I'm sure that Dr. Goebels talked about this, but what you do is you got a little suction cup on the left side. It draws up blisters, and then you sample those blister fluids. Then you come back with the machine, and the machine quantitates how many of these different types of cytokines. The one on the left is IL-6, the one on the right is TNF-alpha in these blisters. And of course, you could identify a clinically relevant subset, measure the cytokines, use a treatment, an immune treatment, like Dr. Goebels talked about, and then you would come back and measure the cytokines to see if it had improved. And this would probably solve the p-value problem, because now you have much more powerful statistics on your side, because you've got quantification, not subjective report of pain and those sort of outcomes. So here's a whole list of clinically significant subsets. You can go through this yourself, but I have to admit that after a meeting of the international research community, this is a short list. There was a much larger list of potential relevant subsets. So we're still debating and discussing the appropriate way to begin to do research in this way, in this regard, and I'll talk to you a little bit about what we've decided. In terms of the treatment, now we do the identification of the relevant subset, but then we have to come back and we have to pick these empirical or logical or experiential therapies. And we've always had this idea that, for instance, if you had the mild to moderate pain relevant subset, that you would use simple analgesics and blocks. So you would identify that specific subset and you would do the thing that is likely to help, and then you would measure the pain again. And unfortunately, in this case, it would be fully subjective. Excruciating intractable pain is different. You would use opioids or stronger medicines for things like that. Inflammation, swelling, you would use steroids. Depression, anxiety, insomnia, you'd use sedative, analgesic, antidepressants, anxiolytics. significant allodynia, hyperalgesia, you might try anticonvulsants, sodium channel blockers, NMDA receptor and antagonists like ketamine. Significant osteopenia, remember those bony changes, immobility and trophic changes, you might use calcitonin, which is a really old drug and very difficult to find, but very effective. It's at the top of effectiveness lists in every meta-analysis of CRPS treatment. Or remember the bisphosphonates. Now the bisphosphonates have all failed. It's a question, a bona fide question, whether or not we're going to even see any more research of bisphosphonates. But after 2 multi-million-dollar trials failing, I think because they didn't identify the responsive subsets, the companies walk away and they take their money with them, and you have perfectly good drugs that are going to treat a solid subset of patients effectively, but they're taken off the market. They never get the indication, and they're put on the shelf, never to be seen again. Profound vasomotor disturbance, as I said, you would measure that. You could quantitate that with infrared telethermography, but very simple things like calcium channel blockers. These drugs are so safe and so easy to use. It's unfortunate that nobody has ever actually looked at this subset. Or sympatholytics, or even the old sympathetic blocks, my favorite thing, which has a very dramatic treatment for the vasomotor disturbance of cold, blue, and sweaty. So I want to summarize what I've said. I'd like to leave plenty of time for questions, but so the summary is we objectively identify a mechanistic subset or target, clinically relevant subset, identify a rational intervention that corrects the mechanistic disorder. We've talked about some of those, drugs or other types of interventions. For instance, the DRG that I think you saw last night. And then you use the same objective test you used to identify the subset as the objective outcome for research. Now in the clinic, you would just use A and B. You would objectively identify, or as objectively as you could, given the techniques that you had available at that clinic, and you would identify a rational intervention, and you're done. You're off giving a treatment that's very likely to help a person that has prominent features of that relevant subset. And then in research, you would come back and use C as the same objective test, as I've said. So use A and B in the clinic, but it's important. It's really important. This does not obviate the need for interdisciplinary and holistic treatment. You're still going to need to do a lot of the things like mindfulness meditation or cognitive behavioral treatments, or identifying sleep disorder as something that is important to treat. So you're still going to need the multidisciplinary treatments, or the if you're lucky to find a academic center that has an interdisciplinary treatment program. So you would certainly use A and B, but because we're identifying a prominent feature of the disease and targeting that, that does not mean that we can't treat all the other parts of this, of course. Now, in research, you would use A, B, and C. Of course, you would use objective testing going forward to get past the p-value problem. So what are we doing? We have this theory. There's a lot of debate and discussion on the international scale as to how to proceed with this. But we in the United States actually, we're probably going to use a lot of international sites to do this project. But we are beginning a project to standardize the procedures for objective identification of the subset, or as we would call it in the clinic, treatment targets, and application of empirical or logic or experiential treatments for that subset. We will then analyze the effect of the treatment using the executive measures used for identification, theoretically solving the p-value problem. And that's all I've got, but I'd like to take plenty of time here to discuss or answer any questions if I can. Anybody out there?
All righty. Can you see and hear me, Dr. Harden?
Yes, I can hear you.
Perfect. So can you see the chat on the right-hand side of the screen?
I cannot.
Okay, it's probably because you are sharing your screen. Well, that's fine. I've been collecting questions throughout your session, so I definitely do have a good amount of questions. And if you can see and hear me, be sure to put your questions here in the chat. We have 25 minutes left with Dr. Harden, so hopefully, we can get through a good number of them. So we have a question from Dylan who says, he's a young CRPS patient who was diagnosed a year ago. He's never experienced allodynia or any topical pain. Is that something that he should expect to see at some point? Does everyone get those two items?
Well, there's been a lot of discussion over the years whether you can have complex regional pain syndrome without pain.
Right.
The pain is usually characterized by hyperpathia and allodynia, but that's not the only types of pain. So you can certainly have different types of pain than that. Technically, with Budapest criteria, you can actually diagnose CRPS without pain, because you'll note that you have to have 3 symptom factors. And one of the symptom factors is pain, but since there's 4, you only have to have 3. So then theoretically, using Budapest, you could have CRPS without pain. But this is a controversial point in not only in the clinical treatment of CRPS, but in the research hands.
Right. We have a question from Christy who asked, have you seen CRPS patients with extreme bone atrophy?
Oh, absolutely. Absolutely. In fact, I didn't put this picture in, but back in, this is a real modern concept. It occurred in 1901. A guy named Sudak took x-rays where he put both, in this case, both hands on the same x-ray plate. So there were no differences in technology or technique. And you saw that there was osteopenia in the affected part versus the unaffected part. So we've certainly known about the osteopenia or bone atrophy, if you will, since 1901. And this, to me, is a very prominent feature or sign of CRPS, and clearly something that the bisphosphonates would be likely to treat, since it's used to treat osteopenia that's not CRPS. It's just older women who drop their estrogen and they start to get osteopenia. These drugs, bisphosphonates, are used to treat that. So I still think those drugs have an awful lot of potential utility. But again, you have to identify the patients that are going to respond to that.
Gidget, and I apologize if I'm pronouncing your name incorrectly, but she said sympathetic blocks made my pain worse. Is this abnormal?
Well, it's not abnormal. And there's an error that some doctors do. If you have early CRPS and it's a hot, red, dry version, that's the acute phases of CRPS usually show that. It would be illogical to use a sympathetic block because that's going to make it hotter and redder and drier, okay? The sympathetic blocks will be used to treat the cold blue sweaty or the more chronic CRPS. So the first question is, at what point in the disease and what type of signs and symptoms did you have when they gave you the sympathetic blocks? But nonetheless, I mean, as in any treatment, if it doesn't help, stop that and try something else.
Right. Cindy is asking, where can CRPS warriors find data that ketamine significantly reduces pain for CRPS. She's asking for insurance approval. Do you know if there's any documentation or that she can use?
There's not a single good randomized controlled trial of ketamine to date, period. And that's very unfortunate. And I have been working with the RSDSA to try to fix that. We certainly have been working in the international research community to try to fix that. But at this moment, there is no evidence at all. And of course, it's very difficult to convince insurance companies to pay for something if you can't show them a randomized controlled trial. There are other things that are ongoing. Another project I'm working on with the RSDSA is to just simply do a good randomized controlled trial of ketamine. You know, part of the problem is that ketamine is now an orphan drug. There is no big drug company owns it. There's no big money available to study the compound, and that, of course, is a real problem. But we're trying to fix that. And again, it's partially the problem is money. We simply do not have money to do those complicated and expensive research protocols. So I'm sorry I can't help with that. There's certainly case reports that you could point to. There are the RSDSA had conducted a large survey of practitioners about ketamine and how to use it, and then they had done a consensus meeting where people face-to-face discuss ketamine and how to use it and what doses, etc., in the hopes that people would pick that up and do the research, but it didn't happen. So we do need to do good research with that, and we are working on it as hard as we can. For instance, I'm thinking about trying to get a large federal grant called the CDMRP. It's an active duty military type of grant to study ketamine appropriately.
Okay. So we had a question from Chuck. I see he's in the comments now saying that sign him up for ketamine, he'll volunteer. But Chuck was asking, he said that he was in the naridronic, I may be mispronouncing that, but he was in the naridronic acid trial that was canceled. Is there a way for him to find out, or anyone for any trial, if they received a placebo or the real deal? How do people ever find that out?
No, you can't find that out. Okay. That obviates the whole concept of the randomized controlled trial. Right. Nobody can know. That's the whole thing about double blinding, is the doctors can't know and the patients can't know. But even if you unblinded it later, it's still going to corrupt the research. So there is no way to know specifically in the trial. Now, there are a lot of bisphosphonates that are available, like I said, to treat other things like osteopenia, and they're out there. These drugs are approved by the FDA. They're sitting on the shelf. What you have to find is a doctor that's willing to use these drugs off-label. And then, of course, in that context, they'll say, hey, it's this drug, this dose, it is a bisphosphonate. How did it go? So there's advantages to using drugs like that in the clinic as opposed to in a randomized controlled trial, because theoretically, unless there's a very serious problem with the drug, adverse event, etc., nobody would ever know. Nobody should ever know whether it was drug versus placebo.
Okay. We had a question earlier from Beth. She asked, is it feasible for CRPS patients to get fMRIs? I agree that the data cannot be argued, but will insurance companies actually pay for the test? I'm sure it depends on the insurance company as well.
Right. It's very unlikely that they're going to willingly pay for fMRI. And part of the problem is that fMRI is considered a research tool in any pain problem. It's never been validated as a diagnostic technique, in this case, in our case, to identify a clinically relevant subset. You would see the part of the brain that lit up that corresponded to the CRPS area and the CRPS pain. You would use some sort of empirical treatment that would be likely to help that type of pain, and then you would see that objective change in fMRI. So it's a great tool in research, but it is it's never crossed the line into a commonly used diagnostic test for CRPS or any pain at this point. It's quite expensive.
Right. A question from Elizabeth that we had earlier. She asked, why do some doctors not understand cold versus hot CRPS? And I guess a follow-up question is, how can warriors better educate their physicians about the differences between the two?
Well, the RSDSA is a vast source of information about what is known and how it's known, how to proceed in terms of diagnosis of the disease, empirical treatments, experimental treatments, what treatments are going on. So I encourage the questioner to pursue some of these resources through the RSDSA to educate your doctor. I'm a doctor, so I can say this, but doctors have a substantial degree of ego, and sometimes they don't welcome patients coming in and saying, "Well, look at this. This is what we need to do." But sometimes you can advocate for yourself in a polite way and try not to trample on your doctor's fragile egos. They can be educated. All these people are trained as scientists, and they should be receptive to science and information and data if it's presented in a sort of polite, non-combative way.
Right.
A doctor that can't distinguish between cold and hot CRPS, and knowing that the one usually occurs early and the other occurs late, you probably need to move to a specialist that really does understand those things. And this is part of the problem that we deal with, that your family practice doctor, they may know about Budapest, they may not. They may not be able to identify CRPS, and that's sitting right in front of them, but they simply do not know what signs and symptoms to look for, and a patient may go undiagnosed. So I would suggest, if you're sitting in a situation where their doctor doesn't identify some of these simple things and will not discuss these things with the patient, it probably is time to move to another doctor, or at least get that family practice or internal medicine doctor to refer the patient to a specialist of some sort. And again, RSDSA is a great resource for doctors who do understand the disease in all local communities. I mean, I got a call from Jim Broach. Do you know a doctor in Vilnius, Lithuania, that treats CRPS? And sometimes I can actually find one. But again, this is DSA working for you guys to find doctors that do understand the disease.
Definitely. And I actually just put a link in the chat, not our list, but a website we know of physicians in Canada. So I definitely shared that. But yes, RSDSA, we definitely do have physicians lists, and we're also trying to build dentist lists as well for every state. And, it's kind of a moving target. Physicians, they retire, they change practices, things of that nature. So we're always trying to get our list updated. But if you need a list, of course, send us an email at rsds.org. But kind of a follow-up to that statement, do you know, Dr. Harden, of any primary centers in the U.S. that are currently doing CRPS research?
Oh, there's several centers. There's a lot of work that's going on, for instance, at Stanford. There's work that's going on at UCLA. There's UCSF. I'm on the West Coast here. On the East Coast, there's work that's being done at Harvard, at Hopkins, My old clinical digs, where I did most of my research, is of course in Chicago, and it is the Shirley Ryan Ability Lab. They used to call it the Rehabilitation Institute of Chicago, but they changed the name for some reason. But it is examples like this. Again, RSDSA is a wonderful resource.
Definitely, we're always here to support.
And they have a list of people that are doing research. In fact, RSDSA is often funding the research.
Mm-hmm.
So yeah, ask them all questions.
And Jim is he's of course in the conference here tonight. So if you see him in the chat, ask Jim a question. But of course, info@rsds.org. And I see Rachel. I see you're asking about Sparrow Clinic. Dr. Katinka will actually be speaking on Thursday night for the conference. So definitely make sure that you come back here on Thursday night to hear from Dr. Katinka. We had another question. I see there are a few questions. And Kelly, yes, I definitely wanted to get to your question. I know it was pretty long. And I definitely want to make sure that I summarize that one a little bit. But there was a question about what if the edema is worse and what has been diagnosed as a sympathetic limb? Does the comparison test verify CRPS in one limb or both? That may have been from part of your presentation.
Well, this of course is a complicated question, which
right.
gets into the, all of our diagnostic criteria have been designed on comparing an affected to an unaffected side. But then in the rare circumstance where the CRPS spreads from side to side, I mean, it often spreads from a hand to a wrist to an elbow, up the arm. That sort of spread is fairly common. It's much more rare when you actually get a true CRPS in one side going to the other side. It's called contralateral spread or mirror spread. But the even rarer situation where you get a hand on one side and then a foot on the other side, that's very rare. I think I've only seen that 2 or 3 times in my entire career, and I've seen thousands of CRPS cases. So I'm sorry, but I was answering a question about side to side. Did I answer the question, or do I need to go further?
I think if that was not the answer that Sally was looking for, Sally just said that's fine. She's in the chat. So.
Oh, okay. Well, read it to me again, and I'll try again, please.
Let me back up a little bit because I'm over here editing some of them in real time. She said, okay. What if the edema is worse in what has been diagnosed as a sympathetic limb? Does the comparison test verify CRPS in one limb or both?
Well, the test that I mentioned was the volumetry, where you put your hand in the bucket of water and see how much water is displaced. Again, this test relies entirely on a difference, theoretically, or at least historically, between the affected and the unaffected side. If you have 2 affected sides and they're both swollen up, you can imagine that it's very difficult to use that test in that case. So I hope that answered the question.
Okay. We have another question from Kelly. Are antibodies in nerve ends indicative of an autoimmune component where her body is attacking her small nerve fibers?
Yeah, this is the autoimmune response, and Dr. Goebbels did talk about that, I'm sure, in some detail. But the idea, yes, in diseases like fibromyalgia, in diseases like rheumatoid arthritis, the body, the immune system, the patient's immune system turns on different tissues in their body. In the case of rheumatoid, of course, it's bone and joint. Well, again, did I answer the question?
I know Kelly's watching, so hopefully, I know she'll, add to the chat. She also mentioned that she had nerve punch biopsies 2 years apart in her non-CRPS limb. She's definitely had a lot of things going on. But I know, like I said, Kelly's watching. So if that's the answer that she's looking for, hopefully she will definitely let us know.
Okay, perhaps we
Okay.
can move on and come back to that.
Kelly said, yes, it does, but I've suffered nerve loss and I've also seen a spread to my GI.
Okay, yes, the nerve damage I mentioned, I showed the little picture of the type of nerve damage that we can measure. Small nerves or pain nerves can be damaged, not only by chemicals or burns, but also by the immune system, and it can be innate immunity versus the tissue. But the big discussion point, the big ticket item, is when the immune system turns on the body tissue. In other words, autoimmune disease, and of course you can identify these antibodies with a punch biopsy, but that that's pretty radical stuff, and it's also experimental stuff. Probably only done in the context of a clinical trial.
So we have about 5 minutes left, and I did see a few other questions that I wanted to touch on really quickly. But before I, jump into those other questions, I also wanted to remind everyone watching to be sure that you register for part 2 of our conference that will take place tomorrow and Thursday. It's a different link. Most of you are already registered for both parts, but just wanted to remind you all, I put the link in the chat and I'm also pinning it here. Of course, email us with any questions, but just wanted to throw that out there before we wrapped up for the evening. Because like I mentioned, we have a few minutes left.
Okay, I'll try to give short answers from here on out. How about
No problem. You've been awesome. So here's a question from Karen. She says that she believes that CRPS has moved to her eyes. We've definitely heard a few people say that. Do I need to be seen by an ophthalmologist who's familiar with CRPS? Or do you think most ophthalmologists know about CRPS? Is it the same as regular physicians or dentists?
Well, CRPS of the eye would be an extremely controversial point.
Okay.
There would certainly be people who had perhaps seen that and been impressed with that, but I would have to say that the international experience doesn't show a lot of CRPS of the eye. Not that it's impossible, but it has to be extremely rare. So my answer to the question is, please go to an ophthalmologist and get them to do a thorough diagnostic workup to try to determine what is wrong. And if, in fact, after no other explanation, remembering one point of the diagnostic criteria is that there's no better explanation. You have to rule out no better explanation when you're talking about eye disease. But if there is no better explanation and it meets criteria, then you would conclude that it would be that extremely rare thing which would be CRPS of the eye.
Definitely. And we've definitely discussed this on our Facebook page before, so I can try to dig up that post because I know there are some warriors who do go to an ophthalmologist who has been able to help them out with that. So definitely send us a message there.
Oh, that's great. And we should probably collect a name of those ophthalmologists so that people that thought they had this or it seemed like there was no better explanation, that we could have ophthalmologists, hopefully several scattered around the country that people could go see and get that diagnosis.
Yeah, we're definitely trying to collect, like I said, dentists and other lists, just because, I feel like we know of a few across the country, but if you have one in California, one in New York, and one in Florida, that doesn't help everyone, in the rest of the country.
I know. It's tough. So just general ophthalmologists could rule out other causes.
Right.
And then if that's what's left, then you may need to travel to an expert in this regard.
Definitely.
Historically, this is a disease of limbs. This is hands and feet, and sometimes knees, and not so often elbows, and I've certainly seen shoulders. But it's pretty controversial whether it actually impacts the thorax, the guts, the head. However, I've certainly heard it. I've heard patients that truly have signs and symptoms, some signs and symptoms, usually never enough to make a formal Budapest diagnosis of the eye or the gut. But clearly they have a CRPS-like phenomenon. And of course, there is a diagnosis called CRPS-NOS, which says there's just no better explanation than CRPS. So
right.
You might have some of these people actually making a diagnosis of CRPS-NOS, which means not otherwise specified. It's in the IASP 2 diagnostic criteria. So it's there. There's a place for all of these things.
Okay. Well, we are going to wrap up for the evening, everyone. This session is wrapping up, like I just mentioned. I have included a link to the survey for this session. Definitely provide us with some feedback. Dr. Harden, thank you so much for joining us this evening. I'm so happy that we were able to get you in your slides and get you on camera. So this was awesome.
All right, great. I hope you have a really wonderful conference, and I hope we've helped.
Yes. Oh, definitely, definitely. And for everyone that's still watching, while this session is over, networking in the expo hall are open until 8:30 Eastern. So definitely go in there and, speak to Jim and Jerry, speak to Brian Pope. He's a national CRPS attorney. He's able to answer questions. You can also network one-on-one with another warrior on camera and on audio via chat. We've seen so many connections. It's been awesome. But thank you for joining us. And of course, send us an email, everyone, info@rsds.org if you have any questions. So have a great night.
All right. Thank you.
Bye.
Bye.